Hello, everyone. I'm Alicia Wolf from the Dizzy Cook, and today I am here with Dr. Ken Watford. Dr. Watford is a nurse practitioner with a doctorate and associate professor at Vanderbilt. He has been there for 25 years and has been treating vestibular migraine specifically for 20 plus years. Welcome, Dr. Watford. I'm excited to have you today.
Yeah, thank you, Alicia. It's my pleasure to be here.
Tell me a little bit more about yourself.
It's been an interesting journey in education. I came to Vanderbilt in the Department of Otolaryngology, head neck surgery in 2000, and drifted more to otology, neurotology, and specifically treatment of dizziness of all sorts. And I've been doing that 25 years. And vestibular migraine began to become a thing in about 2000. I mean, about 2005, I would say, maybe 20 years ago. And we've learned tremendously about vestibular migraine and other types of dizziness, and that's kind of what I do all day, every day.
Interesting. How many patients do you see that have vestibular migraine per day? Do you?
Ooh, Lord. I have a mature practice after 25 years, so I see less new patients. It used to be 14, 16 a day.
Wow.
And now there's 4 to 6 a day. But vestibular migraine is something you're going to have your whole life. Patients with vestibular migraine have had it their whole life, and it evolves and comes up with new symptoms. So I see 8 or 10 return vestibular migraines. Once they're stable, I see them once a year. I need to see them once a year to check in, and sometimes I need to prescribe medications. But for the most part, that's what I do all day.
Interesting. What other vestibular disorders do you see?
Meniere's disease, that's something we also have excellent outcomes with. I treat vestibular neuritis, which is really more of a one-time event. It's not a chronic condition. I treat benign paroxysmal positional vertigo, BPPV, and that's common. And I treat a lot of that every day. Um, and of course, vestibular migraine. And mixed in with all of these conditions is triple PD. That's often comorbidity with vestibular migraine or Meniere's or neuritis.
Interesting. I was wondering how often people tend to cross over with each other.
Very often, high comorbidities between all of these conditions. I see patients who, were diagnosed with unilateral hearing loss in the low frequencies, attacks of vertigo and tinnitus in the affected ear, and at some point later they developed headaches, which they kind of migrated over into vestibular migraine. And then at times they have benign paroxysmal positional vertigo. So they've got three things. And then on top of that, they may develop triple PD. So they may have four things going on. It's important to help patients learn to distinguish which is which, because each of these requires different treatment. And so what works for one doesn't work for the other. So that's kind of I help my patients understand what's going on. I spend a lot of time with my patients. I'll ask a lot of questions and I listen. And largely we have excellent outcomes with all of these diagnoses.
Interesting. So I know vestibular migraine doesn't really have a test for it. There are tests that you can do to eliminate some of these other vestibular disorders, but it really does come down to the practitioner listening to you.
Right.
Can you
It's
tell
a
me?
diagnosis. I'm sorry, go ahead.
Go ahead, please.
It's a diagnosis based on exclusion. You're right. There is no test for vestibular migraine. So we do the MRI to rule out a tumor. Just being thorough, and I'm all about peace of mind. And if a patient at 3 a.m. is wondering do they have a tumor, we eliminate that possibility in the beginning. I get vestibular function studies on those patients. Of course, we start with an audiogram hearing test, but we can measure the balance nerves of the inner ear. And vestibular migraine, those patients are generally normal. They don't have an inner ear problem. So the International Headache Society, large group of mostly neurologists, met in Europe, 12, 15 years ago, and they called this thing vestibular migraine. And they came up with diagnostic criteria, and basically like last criteria, if it's not anything else, it's vestibular migraine. We know it's the number one cause of dizziness now.
Mm, interesting. Um, Tell me a little bit more about yourself. I know you yourself struggle with migraine too.
I did. I didn't really know I had migraine until I turned 59 and a half, about a year and a half ago. I know as a kid, I wore sunglasses all the time, even in the morning when it wasn't that bright, or even in the evening. So that was migraine back then. I didn't have really significant headaches until about a year and a half ago when I began to experience, for no good reason that I could figure, totally incapacitating headaches. Lay in my bed, curtains drawn, lights off, can't look at a screen whatsoever, don't move my head, crawl to the bathroom and be sick. And that may last 15 hours, that may last 36 hours. And, after 7 or 8 times in a month, something had to be done. And, so Mother Nature has a warped sense of humor, maybe, and gave me what it is that I treat all day long for the last 20 years. So now I can relate much better to my patients, and I can explore other treatment options for my patients that I explore that help me myself, that also can help my patients.
I think you brought up an interesting point that, migraine can sometimes be there in the background and we just don't always realize it. Like for me, I was always very motion sick as a kid, but it can change,
Correct. Correct.
you know? And sometimes we just, there's no big reason that we can pinpoint to. It's just sometimes it changes throughout our life and becomes more apparent.
Yeah. It will absolutely evolve throughout a person's lifetime. So I help patients understand this will evolve. I'll go on this journey with you. And as it evolves, we will evolve and we will have treatments for these new symptoms. But I personally think when a person has migraine, they have it their whole life. They're probably born with it. There's a strong genetic correlation in patients with migraine. That's one of the questions in the 75 questions I ask a new patient with dizziness. Does it run in the family? And usually, maybe the patient says, "Yeah, Aunt Susie has this terrible headache. She goes to bed, she's vomiting, turns the lights off, but I don't have that. Maybe I have facial pressure. Maybe I have, like knee pressure here." Um, they think they're having a sinus headache, and they go to a walking clinic. They're given antibiotics over and over and over when they never had a sinus infection in the first place. We did that study 20 years ago, and patients who had facial pressure, facial pain, pain between their eyes or behind their eyes. We did CAT scans of those patients, and 98% had completely clear sinuses. They had facial migraine.
Yeah,
So treat it like a migraine. Don't give antibiotics.
Mhm. And I see that so often too with my followers. They're like, well, I just have sinus issues, and they don't actually know that they're
Yeah,
having
yeah,
migraine
yeah.
attacks.
It's a migraine.
We're so caught up in migraine always being a bad headache, which is why it took me
Right,
so long to get diagnosed because I wasn't
right,
having head pain with my.
right, right. So let's redefine what migraine really means. You can have a migraine and not have a headache. It may be only dizziness, and that dizziness may be true vertigo. It may be I feel like I'm walking on marshmallows. It may be I feel like I'm rocking on a boat. It may last for seconds. It may last for weeks without stopping. So let's redefine what a migraine really means, and all of this will make more sense.
Yeah, so once you can wrap your head around that, I feel like you're more accepting to, okay, this,
Sure.
I'm going to go forward and treat this.
Sure. Some will have sensitivity to light or sensitivity to sound. Some don't. Again, some will have dizziness, some don't. They probably at some point will. So I prepare them for that so that when it occurs, they're not frightened. They know what's going on. Like, oh yeah, this is just my migraine evolving. And then we talk and we come up with remedies for these new symptoms.
Okay. What are the most common symptoms that you see in your clinic?
In vestibular migraine, I primarily, again, I'm an ear specialist, so historically we've focused on dizziness. Dizziness can either be peripheral, which is inner ear, or
Okay.
central, which is brain and central nervous system, which is typically treated by a neurologist. But maybe 20 years ago, it was hard to find maybe neurology who would treat dizziness.
Mhm.
And so we had a hard time finding uh, healthcare providers who would treat these patients. So that's why, 20 years ago, as an ear specialist, I began treating dizziness that was not an inner ear problem. In all reality, I think we're growing and learning exponentially about vestibular migraine. It's a great time right now to have migraine, if you can say that, because there's lots of new treatments, there's lots of research, there's understanding. I think migraine probably affects the inner ear and the brain, so it's probably peripheral and central.
Interesting. That's really interesting to hear from your perspective too, because I feel like a lot of people just don't know where this dizziness is coming from and
Right,
who to see either. And so they're like,
right,
who's the best doctor to see? And usually my recommendation is, well, you hit all kinds of doctors who treat this.
right,
You can have an
right.
ENT or a neurologist, but the really what's important is that they focus on this type of migraine. And if you can find someone
That's
with
correct.
specialty, which is difficult to find, it can
Yeah.
be incredibly helpful.
It's probably multidisciplinary, and I try to use again a mostly disciplinary approach, and maybe we all have a role in treating this, both otolaryngology and neurology, integrative health, all of this.
So let's get into how we treat this. That was one of the biggest questions I got from followers were where do I begin treating VM,
Okay.
vestibular migraine, and triple PD?
So so we'll talk about triple PD
Do.
in a moment. Let's focus on the
Yeah.
vestibular migraine. So it had been well established for decades that patients who had the classic migraine headache that you think about as Aunt Susie, turn the lights off, vomiting, or go to bed with excruciating pain. It was well established if those patients who had classic migraine headache, if they avoided triggers, food triggers, lifestyle triggers, they would get better. There's hundreds of thousands of peer-reviewed papers published on that. But what about migraine dizziness, with or without headache? They would get better if they avoided, followed the same lifestyle guidelines and dietary guidelines that traditional migraine headache patients. So we did that study 4 years ago. We took patients who met the diagnostic criteria, the International Headache Society criteria for vestibular migraine. And we agreed we were not going to prescribe medicines for 2 months. Again, nobody's looking for another pill to take every day. Nobody, not any age. So we agreed we were not going to prescribe medicine for 2 months. All we were going to do is change their diet and equally important, their lifestyle. So we asked patients to fill out a couple surveys that focused on quality of life. This is really about quality of life. How can I help your quality of life be better day to day? It's not about headache. It's not about dizziness. So patients filled out quality of life metrics. One that we call the dizziness handicap inventory at Vanderbilt that was designed there by Peter Jacobson in audiology, and also a headache disability inventory, also designed by Gary Jacobson. Is I filled out the two surveys, 0 to 100, what effect does dizziness or headache having on my quality of life? 100, of course, is as bad as can be. Anything over 54 is incapacitating. Anything in single digits is not significant. To fill out surveys, we gave them a list of foods to avoid, and I'm happy to post this in the comments. This study it was published about 3 years ago in the Journal of Otology and Neurotology. And so patients went home, began their own migraine diet and lifestyle that we gave them, and we would see them back at 2 months. Did they get and they would fill out the surveys again. Did they get better, worse, or was there no change? I would say in the patients who I had in the study, and the data later confirmed this, 50% of them, it just went away.
Wow.
We didn't add any medicine. 50% of them, it just went away. Other people got a lot better, but there were breakthrough symptoms. Days with nausea, days with headache, days with dizziness. And for those patients, we would prescribe rescue medicines, rescue for dizziness, rescue for headache, and rescue for nausea. And we could talk about those later. Finally, if there was not still quality of life improvement that we were looking for, maybe the patient just wasn't able or wasn't willing to follow a strict migraine diet and lifestyle. And for those patients, we would prescribe daily preventative medicines that you take day in, day out. The challenge with that is every vestibular migraine patient is different. I've never seen two just alike. Never seen two just alike. So trying to find the medicine that works for them at a certain dosage without side effects is a bit of a trial and error. It's a bit of a challenge. But I have some of my favorites, and again, we will eventually find the combination for work that works for that patient and improves their quality of life.
It's really interesting. So after 2 months, if they weren't seeing a huge improvement, is that when you would bring in the preventative medications, or
That's
if
correct. That's correct.
like we don't have
Yeah.
time for this, would you bring it in?
Re Correct. Rescue medicines, we wouldn't start until 2 months. We've since published studies that show that the average time for improvement or resolution was 14 days. Many of those patients got better or it was resolved within 4 days. So now I simply ask patients to follow a strict migraine diet and lifestyle for 2 weeks.
Okay.
Anybody can give up their pot of coffee for 2 weeks, maybe. We taper them off gently so they don't have rebound headaches. But anyone can follow these guidelines for just 2 weeks. And what if they do these things and in 4 days it's gone?
Mm-hmm.
And
That's
that's a reasonable expectation.
yeah. So is that what you guys still see in your clinic? Is that people are responding incredibly well to these diet and lifestyle changes?
Incredibly well. And again, it's something that we're ongoing. We're looking at now. There's two approaches to treating vestibular migraine. One may be more otology, neurotology. Maybe one's more leaning toward neurology. And again, we have different approaches I've seen, and not only at Vanderbilt but around the country. And again, personally, I lean heavily on non-pharmaceuticals.
Okay.
Um, what if they do these things and in 4 days they're better, but if we need to use daily preventative medicines, we can.
Okay. Can you explain some of the lifestyle changes that you ask
Yeah,
people to make?
yeah. Stress.
Yeah.
Number one overall trigger, stress. And I have to define what stress means because I'll have patients, well, I retired, I don't have any stress. Well, stress may mean fatigue, anxiety, worrying, depression. I didn't sleep good last night. I'm worried. I'm living in the future. I'm living in the past. I've watched too much politics.
Mm,
All of that means stress. I don't know of one person in this country who's not under some degree of stress. So let's redefine what stress really means.
okay. How do you get the patient to realize that?
We have this discussion just like you and I are.
And
So, lifestyle modifications that we asked patients to do in the study 4 years ago. We asked them to have good sleep hygiene. We asked them to have restful sleep. Uh, Poor sleep is probably maybe the number two overall trigger. And poor sleep is kind of stress, really, when you think about it. We
yeah,
ask patients to drink lots of water, 60 to 80 ounces of water. Dehydration tends to be a major trigger. I live in Tennessee, where we have high heat, high humidity, both triggers. We have thunderstorms, changes in barometric pressure. Almost universally, I'd say, is going to be a trigger for patients with vestibular migraine. We have kind of poor air quality in Tennessee. They don't call them the Smoky Mountains for nothing. Tennessee is considered the number one worst state in the country for vestibular migraine.
huh,
We have the second worst air quality, and most people don't realize that. So we also ask patients to not skip meals. When you skip meals, your insulin glucose fluctuates, and that can be a trigger. So getting hungry can be a trigger for vestibular migraine. And then finally, the way we countered stress in the study, we simply asked patients to walk 20 minutes 5 days a week. Exercise reduces stress. So exercise, if you do the things that bring you joy,
yeah,
exercise reduces vestibular migraine. If patients can exercise, like walk 20 minutes 5 days a week, some of these people are not able to do that. There's other ways of lowering stress, such as meditation or swimming, or, my walking is hiking. I hike in national parks around the world. And that's stress relieving for me. So that's one way I lower my stress. Those that was the lifestyle modification uh, leg of the treatment, but equally important would be dietary changes. I've had patients say, "Well, look, I followed a strict migraine diet for 2 weeks. I'm not any better."
mm,
Well, what about the lifestyle modifications? Are you getting good sleep? Are you under high stress? Are you drinking a lot of water? It's everything every day. It's not just one thing.
Yeah.
So if you want to talk about, I know if you research there's lots of migraine diets.
Mhm.
We had one, and again, I'll include it in a link that will give you the migraine diet that we use. It's things that you might commonly think, caffeine, artificial sweeteners, and I think all of them. I used to think D was okay, and stevia turned out to be a big trigger for me.
Yeah.
It's chocolate, which is caffeine, and it's alcohol. It's probably not all alcohol, but certainly, even in my 20s and 30s, red wine would always give me a headache. So again, I was having migraine way back then before I had incapacitating migraine and vestibular migraine. There's a lot of foods on the list that we would consider clean eating, and I
Yeah.
would consider clean eating if it wasn't for migraine. It's nuts, cashews, almonds, walnuts. Uh, Peanuts and peanut butter. It's things that are aged or fermented. So the pepper jack cheese, the Colby jack cheese, the mozzarella and the American cheese. That's not a trigger. It's not aged or fermented. It might be the buttermilk, the sour cream, the yogurt. It might be the pinto beans, the snow peas, the red onions. It might be the nitrates that are in bacon and sausage. It might be the yeast that's commonly reported to me by patients that's in most bread.
Isn't
It's a
that
lot of things.
that one always gets me? And sometimes I have people, they say they swear by waiting till the next day or freezing it. That seems to help. But
Yeah.
the yeast one is really interesting to me all the
It is, and I'm just kind of mentioning. It's so interesting. I learn so much from my patients, and
time.
they help me. It's a two-way street. Maybe I help them. I hope so, but I learn a lot from my patients, and I learned. Patients will tell me. I had one a couple days ago that said lemons and limes. So citrus is on our list.
Yeah.
That tend to be a trigger for them. Of course, things like MSG that patients had learned. So sugar is not on the list. I think sugar is a potent migraine trigger. And I learned, I turned 50 and the pint of Ben and Jerry's at night when I went to bed. I
Yeah.
grew up on that in rural Mississippi on a farm. Sugar was love. It was Valentine's. It was good grades. It was Christmas. It was holidays. And then sugar, I think, turned on me. I think we're going to find that migraine is an inflammatory condition. And inflammatory foods tend to be big triggers, and sugar is maybe the most potent inflammatory food. There's not any good reason, I think, to eat sugar.
Yeah, it's
It
interesting.
makes us hag, but
I recently did a little poll with my audience, just to try to figure out like what recipes to do for this year. And
sure.
some of the most common triggers I heard, the number one was stress and
Mhm.
hydration, lack of sleep, and then down there was food triggers. I think it was like the third or the fourth. But
Yeah,
most common food triggers, MSG was way at the top,
way, way
way
up
at the
there.
top, which was interesting. And sugar was very low, but in the same responses that I got, a lot of people said they were having success with balancing their blood sugar and eating high protein,
Right,
well-rounded meals with like lots of fiber,
right.
fats. And so sometimes I wonder, if it's maybe pairing the sugar with these things, if you're going to have it, or
Sure,
reducing it in a way.
sure.
But it's interesting you mentioned that because keto can be so helpful for some people, or low carb. And then,
Right,
but like the sugar substitutes, I also seen were like one of the most commonly reported triggers.
right, right. Again, this thing evolves. I probably did keto for 5 years. I felt great. I lost weight. I had energy. But I was eating for breakfast, bulletproof coffee, high caffeine, and I would add butter and I would add cream. I was doing nuts. I was doing bacon. I was doing cheese, and that worked wonderful for me for 5 years. And then it didn't. Those things turned on me, and again at age 59, those things I couldn't do any longer. So it evolves, and just because this particular food or this particular food is not a trigger now, doesn't mean in 5 years from now it won't be a trigger. So again, migraine's a dynamic process, and so we just have to adjust. And And again, I'm here to help patients understand and to anticipate, what if at some point I start having this symptom with this food? Then we adapt. And if it's not causing a problem, it's fine to have. I tell my patients, I give them this list of food and they say, "Oh my God, I eat all of this. What am I going to eat?"
Yeah.
And I said, for 2 weeks, you're going to eat anything that's not on this list. But I also reassure them this is not overwhelming. 98% of the foods on the list are not going to be your triggers. The
Yeah.
key is to find your trigger. So I ask them to do a strict everything every day migraine diet and lifestyle.
Mhm.
And then once you're feeling better, and let's just say you're feeling dramatically better in 4 days or in 2 weeks, then start reintroducing the foods that bring you joy that are
Yeah.
not a problem, reintroduce them and eat the things that you enjoy. And again, if you introduce it and it makes you feel bad again, you know your triggers. So typically, patients generally report 3 or 4 triggers out of a list of maybe 100.
Yeah, it was the same thing for me. What I
Mhm.
ended up being sensitive to was caffeine. Caffeine is still a
Yeah,
really big one
yeah,
for me. Nuts were really big, especially walnuts.
yeah,
Yogurt. Yogurt was a big
yeah, yeah. You're
one.
you're describing my patients.
Yeah. So let's say, I'm about like not, this will be my ninth year with vestibular migraine. And I went from
Mhm,
24/7 chronic to remission. And then I had two
mhm,
kids. For those who don't know my story, had two kids. One was IVF, and I
mhm.
started to have more low frequency episodic attacks.
Yeah,
Then this past year after my daughter, my attacks started to change where I was having more head pain.
right,
And this was very different for me because in the past I had only had dizziness and vertigo. I
right,
never
right.
had the head pain part of it. So I started to wonder if maybe my hormones were changing, which they
Mhm.
are. But a big
Estrogen.
yeah. Another thing that I found out through lots of testing was that I had low ferritin. So getting
Yeah,
my ferritin up,
yeah,
the hematologist is
yeah.
helpful. But I've been trying to reintroduce some of these foods now that I'm feeling better, trying to
Hmm.
bring back some of these foods in, and I've been able to incorporate a small amount of nuts and some
Yeah,
of the Icelandic yogurt, the skyr, I think
right,
it's called skyr.
right.
And so I've been testing the waters there. Caffeine still gets me. I can't do
Yeah,
caffeine, but
yeah,
it's a really good point that these things may not be triggers forever. And, it's a good to have a varied diet. And so we want to work with our migraine, but also
right.
balance it. Yeah.
Ask patients to be acutely self-aware. How
Mhm.
do I feel after I've eaten? And it may be 15 minutes, it may be 24 hours.
Yeah.
And again, if it makes you sick, why are you eating it? And again, I help patients understand those things. And again, let's understand that this concept is really important. It wasn't just the caffeine, it wasn't just the stress, it wasn't just the weather changing, it wasn't just the fluctuations in estrogen.
Mhm.
It was all of them.
Mhm.
And so if we can, if there, I say there's probably on any given day you have a bad day, I'd probably say there's 5 triggers and they had an cumulative effect and you had a bad day. What if you got rid of half those triggers? You wouldn't have a bad day. So
Right.
let's identify our triggers. Let's limit those triggers. For example, when I travel, again, ever since COVID, I get out of the country every 4 to 6 weeks and I travel in national parks around the world by myself and it brings me joy. Um, in COVID, there was no one traveling internationally, so the planes were empty and the hotels were empty and there were no tourists. I had a high risk job. I was coming to work and looking in the nose and the mouth and the ears of patients that perhaps had COVID. And, I got COVID 6 times, and we'll talk about COVID and that relationship to vestibular migraine as well. And so when I would travel out of the country, I'm just as happy as can be. I have peace of mind. I sleep like a baby for whatever reason. And I can get up in the morning at the hotel and I can have a cappuccino, maybe 2 cappuccinos, and it doesn't affect me. I come home where I tend to be maybe I don't sleep as well and I'm under higher stress. And 15 minutes after I have my decaf, I have this, and that will escalate. into a more severe or incapacitating headache through the day. I do have rescue meds that I can take just to abort that process. But so let's think about the cumulative effect of triggers, and let's know. It's so important to know your triggers. There are meds that can be used to as preventative. If you know the weather's going to be changing in 2 days or tomorrow, there's going to be storms or snow. Maybe there's meds that you can take prophylactically that will prevent you from having symptoms from those variables, those triggers that we can't control.
Mhm. At pre-treating is one of my most
Exactly.
valuable things that I have ever learned. And it's what you're saying. You end up taking your medication before you even need it, before you have
Correct. Correct.
maybe see a potential trigger happening. Maybe it's taking a
Correct.
flight, a long flight, a stressful situation with family. You are, things out of your control, but you can
Correct.
control taking those acute
Correct.
medications
Correct.
beforehand.
Correct.
Is that something you see very helpful in your practice too?
Absolutely. Absolutely. So I try to enable my patients. This doesn't control you. You can control this. And
Yeah.
that takes the fear away
Mhm.
and that empowers us. So there are rescue medicines, rescue for dizziness, rescue for headache, rescue for nausea. If all those symptoms are going on at the same time, you can take all the medicines and we can talk about the specifics, or you can take whichever medicine is correlating with your particular symptom. And generally these are very effective, 15, 20 minutes. And if you take the medicines early, that's another thing. Take the medicines early if you need them. Don't wait. For example, if I have a 1 out of 10 headache, I don't take anything. If I have a 2 or 3, I go ahead and take the rescue medicines. If I wait till it's a 4 or 5, I don't find anything helps but sleep at
Yeah,
that point. So some people want to push through and not take the medicines, and I'm going to beat this thing, and I'm not going to take this medicine. I encourage them, go ahead and take the medicines early. You'll take less medicine if you go ahead and take it early, if the goal is to take less medicine.
versus trying to catch up after things have already gotten bad.
Yeah, you'll take a lot more medicine and you'll probably lose. You'll end up going to sleep, and you'll wake up and it's gone.
Let's talk about maybe some of your most commonly prescribed medications for
Sure.
each of those, for the head pain, for the dizziness, and for the nausea.
And again, let's redefine what the head pain really means. The pain may be brain fog. I call that a migraine. It may be facial pressure, pain behind my eyes. So let's identify what a migraine really means. It doesn't have to be incapacitating headache to be a migraine.
Right.
I find the triptans, they've been around for decades, and they're still some of the best meds out there.
Okay.
And there's a bunch of different ones. I like rizatriptan. It's sublingual, so it goes under your tongue, and if you're vomiting, it doesn't matter because it's going to go straight through your bloodstream and avoid your GI tract, so it works quicker. Usually for me, 20, 30 minutes, maybe 15 minutes, and the headache's gone.
Okay.
I like the benzodiazepine, specifically diazepam.
Mhm.
And the word Valium carries a lot of baggage because it was used in the 60s as a recreational drug at much higher doses as a tranquilizer. But micro dosing of Valium, I think, is the gold standard. I've been using it for 25 years. I've not seen any patients, even though it's a DEA controlled substance, I've not seen any of my patients out of thousands or tens of thousands that developed red flags of dependency. It's a safe medicine. My goal is to use the least amount of medicine that will control your symptoms. For some people, that's one tablet. I write 2 milligrams. It comes in a 2, 5, 10, and 20. I write 2 milligrams. Patients can break it in half. They can break it in fourth. The goal is to stop your medicine without side effects. So if it makes you loopy or drowsy or tired, you're taking too much. So lower the dosage. And I would say this is anecdotal. I would say there's a 98% probability you'll find it extremely helpful to put in your toolbox. You always carry it with you. They stay in my backpack, my rescue meds, because again, earlier is better. I don't like meclizine. Antivert. It's very commonly prescribed in the ER and the walk-in clinics and the primary care. And I try to help edit textbooks and take that out. It's an anticholinergic antihistamine drug. It affects cognition, it affects memory, it affects reflexes. So I give a patient who's unsteady, a patient that then slows their reflexes, I just increase their risk of falling.
Yeah.
It's over the counter. I don't ever recommend it. And if a patient's on it, I take them off and we put them on micro dosing of diazepam. And that's the one I prefer. It's fairly short acting and it works quickly and it doesn't stay in your bloodstream a long time.
Okay, that's really interesting to hear because I had a lot of success. I've used both Valium, diazepam, and lorazepam, so
Yeah,
Ativan.
it's a similar, Ativan is similar, and you find the one that works for you.
Yeah, and I get a lot of judgment for sharing about it, but
Yeah,
I was very careful with my neurologist, and I think if you have a good doctor who can follow up with you, and it was the same thing. We microdosed it. So just because
right.
the pills come in this full amount doesn't mean you have to take them that
Yeah,
way. And they
yeah,
can make you groggy that way.
yeah,
So if you're finding yourself waking up the next day and extremely groggy, you can, go down a dose and start to break it and
yeah,
see
yeah.
what works for
A
you.
fourth of a tablet, which is a half a milligram, may be perfect for you. And
Yeah.
again, if you wanna go to sleep and be impaired, take meclizine,
Yeah.
Dramamine. I rarely have any patients tell me good things about that experience.
Yeah. I'm curious about the nausea side of things. Is that something you see
I
helpful
do,
in or?
yeah, I do. And again, if the patients don't have nausea today with their migraine, give it a year or two or 5 or 10 years. It will probably come along at some point again because this thing is evolving. I like ondansetron,
Okay.
Zofran, and it's non-sedating. I write the ODT form, the sublingual form, again, just like the Maxalt or rizatriptan. It works quicker, and again, there's probably a 98% success rate with it. Rarely do patients have any side effects. There's other things that patients like to use, like peppermint or ginger, and that's fine too. I'm okay with that. Again, the least amount of medicine that will control your symptoms. But there is a role for pharmaceuticals in this diagnosis. And so again, I like it's about peace of mind, and I want patients to have something that they can take. Let's say they go on a big trip and they're in an international airport, they're not drinking enough water, they're eating the things they shouldn't be, they're stressed because of delays, they're tired, they're not sleeping, and I want you to be able to have something. If you have a major attack of vertigo in an international airport and 911 is called and you have $100,000 hospital bill in another country where your insurance doesn't cover it, when a penny's worth of diazepam would have stopped it 20 minutes later. Again, let's empower our patients.
Yeah, exactly. I mean, it's also peace of mind for me too when I'm out doing my
Correct.
because you
Correct.
can't control your triggers all the time as much as
Correct.
you do.
And there's again those that you can't control like the weather.
Yeah. So let's talk a little bit about so these things that we just mentioned are not things that are used preventatively every day. They're just on
Right.
occasion for these situations that may come up or for pre-treating. What do you see very helpful preventatively every day outside of
Sure.
the lifestyle and diet changes that we recommend?
Sure. There are meds, and there are probably 100 or 200 different medicines that were designed for something else, and someone figured out, hey, this works great to prevent migraine.
Mhm.
I like I like nortriptyline, I like amitriptyline, the tricyclics that were designed again a long time ago. So but I do start on micro dosing. I won't prescribe a patient, 50 milligrams of nortriptyline because they can't get up the next morning. They're so groggy. So why don't we start at 10 milligrams for a week, and then we can go to 20, and then we can go to 30. You find the dosage that works for you that doesn't cause side effects. Like I mentioned, amitriptyline is one that's often considered the gold standard, and we're doing that head-to-head study. Is amitriptyline better, or is diet and lifestyle? Changes better. I think we're going to find diet and lifestyle actually beats out amitriptyline, but that's yet to be determined. We'll have that discussion later. We'll have those results in the next few months.
Okay.
There are SSRIs that can be helpful. This are SNRIs, serotonin, nortriptyline are the feel-good hormones. That's why, by the way, we can talk about neuromodulators because those things boost serotonin, norepinephrine, and help us feel better. There's a large number of different classes of drugs, some seizure drugs, some hypertension drugs, calcium channel blockers, beta blockers. There's a lot of options. And again, I just want my patients to know we will find the combination that works for you. These are some of the favorites that I start with, but we'll find the one that works for you. One I've seen helpful lately as a preventative is Lyrica, which is for me personally, I was put on that, and it was like a miracle drug. Not only does it reduce or eliminate neuropathic pain, the back pain, the fibromyalgia, the things like that, it does now have an indication for, but it also prevents migraine. So we can have meds that have dual benefits, and that's a win-win. So I look at my patients' other comorbidities, and what if we can give a medicine that one medicine works for all these problems? Again, the least amount of medicine.
Mhm. That's the same way my neurologist, Dr. Bay, works as well. It's like, okay, if there might be other issues going on here, like anxiety or depression, or what else is going on here that
Correct.
we treat. Sometimes they find like with triple PD, sometimes the anxiety
Correct.
can help if a patient has a lot of anxiety around triple PD and VM.
There
Um,
are a lot of comorbidities with migraine, triple PD, anxiety, depression, um, BPPV, Meniere's disease. Again, all of these, we might find that a lot of these are inflammatory conditions or maybe autoimmune disorders. Again, we don't really know what causes migraine. We don't know what causes Meniere's. It's something I've been treating for a long time. And before we even knew what vestibular migraine was, some of those patients didn't have hearing loss, and we thought they had early Meniere's. Turns out they had vestibular migraine, and they never developed hearing loss, but eventually they developed the headache.
yeah, that's interesting how much we're learning and how open you have to be to the.
It's an exciting time in vestibular migraine. If you're passionate about it, like I am, maybe you can feel that. I'm passionate about learning. I'm passionate about vestibular migraine. I'm passionate about helping my patients, and it's an exciting time.
Let's talk a little bit about nervous system regulation. Do you find that to be
Sure.
helpful for your patients?
Of, of course. The sympathetic nervous system is activated in stress.
Yeah.
And fight or flight, adrenaline. Of course, that's that we've talked about. That's a big trigger for patients with migraine or vestibular migraine. So, and if we can help those patients pass from the switch over the sympathetic nervous system to the parasympathetic nervous system, which is calmness and well-being, peace of mind. Then we've eliminated those triggers. We've helped those patients. I'm a big believer in meditation. I meditate 20 minutes twice a day. That's a way of bringing more peace of mind and eliminating or reducing the stress. I'm fortunate at Vanderbilt. Vanderbilt's been putting money into integrative health and a holistic approach, Eastern medicine, Tai Chi, Qigong, meditation, acupuncture, which is another layer of treatment. Acupuncture, I think, has its role.
Mhm.
So I send those patients who are under high stress and I said, I'd love you to learn a practice of meditation. If that's not it for you, then Tai Chi or Qigong or yoga, all of those things shift from the sympathetic nervous system over to the parasympathetic system and reduces migraine and brings peace of mind.
That's really interesting. I kind of went on a similar journey myself when I was trying to look outside of medications because I started the opposite way, which I think everyone thinks I just started with diet and then it took care of all my issues, but that's not how it would happen. I initially started with a preventative, so that was Timolol eye drops for me.
Yeah,
And then I was
yeah,
on a low dose of lorazepam that
yeah,
every day until we
yeah.
weaned that. And then I was trying to get my sleep schedule in order and hydration.
Hmm.
But I ended up looking, okay, what are my other natural treatment options?
Mhm.
I think a lot of
Right.
doctors out there put down diet because either they think their patients won't do it or they don't.
They won't do it. Yeah, they will do it. If you reassure them, they will do it. And I've heard that before. Well,
Yeah,
patients just won't do it. I strongly disagree. And you know that already. You've written books about this.
yeah. We get to the point where we're like, okay, I will do anything. And I think
Correct.
um, maybe a part of it is that providers don't have the right tools to support
Yeah,
patients in these things.
that's right.
So you were telling me about a handout you give to all of your patients
Yeah,
too with all
yeah.
things.
I give again, I spend at least an hour, maybe it's longer, in a new patient with dizziness, and I don't expect them to remember all these things. You and I are talking a lot about the things I talk with my patients on the initial visit. It's a
Mhm.
lot of information. So I give a handout in a nice glossy folder, and I give what we recommend as a migraine diet and lifestyle. I include the publication, and again, I'll include that just so that it shows it works. It was published in a peer-reviewed journal article, and then there's subsequent publications as well. I give them options like integrative health. At Vanderbilt, we have a center for integrative medicine called the Osher Center. There's six in the world. They're quite reputable. And but basically, if patients can't, not all of my patients, they may have traveled several hundred miles to come to for this visit. So they can't come back and forth to learn how to meditate or to learn how to practice yoga. But there's generally YMCA's. There's other resources. So I give a handout about the importance of that. I give some handouts I include in the packet about neuromodulators and their benefits. And again, those are fairly new, but I think they can be very helpful. I give a handout about I have patients who can't tolerate going into wine working out because the lighting is so harsh. There's so much busy things going on that they can't tolerate it. Or they go to the grocery store and busy visual stimuli tend to be a big trigger. So walking down the grocery store aisle can be a big trigger, especially with the fluorescent lighting. So there are glasses that can help. And you introduced me to Avalok's glasses, and I'm early on in my learning process, but I put on a pair of them and they feel good. And again, I have a patient that's sitting in my exam room because of the stress of getting to their appointment and the traffic and the parking and the waiting and the elevators. And
Yeah.
I go in and put a pair of glasses on them and I can turn the lights on and they can talk to me and it feels good. And there's a lot of engineering behind these glasses. They're not just blue filtering glasses. There's a lot more engineering to them. And again, I'm still early on in the learning process. And I thank you for introducing me to Avalox. But I include that packet as well.
Awesome. To go back to where I kind of was in my journey trying to figure this out, and your point on acupuncture and everything, I tried a lot of these different areas to see what was going to feel good for me. And so I ended up not feeling great with acupuncture. The needles and everything, I just couldn't like find relaxing. And maybe it was who I was going to, I don't know. But what did work
Yeah.
well for me was acupressure. So just,
Yeah.
just tweaking a little bit.
Yeah. Yeah.
I found,
Or maybe therapeutic massage.
yeah,
Um,
I
for
had
for
a lot of
me,
success with massage
I'm
therapy.
sorry, Alicia, go ahead.
Well, I was just saying I had a lot of success with massage therapy
Yeah.
and
Yeah.
actually incorporated some of these techniques.
Yeah.
Um,
Whatever works and does no harm.
yeah,
And again, it's a process of trial and error, and there's so many options. And I want my patients to know we will find the remedy for you. We will get you back to quality of life like it was before all this happened. And I want you to get out and live your life, live your best life. And again, be very optimistic. I ask my patients, we will find that combination.
yeah.
We'll get you back there.
And I think a lot of people with this get hung up on, I just want to be cured. I want to never have to deal with it again. And
Yeah. Yeah.
kind of forget that you can still have, it's like we were talking about with quality life. You want to have a good quality of life. Like you can live along with this and not have it affect your quality of life or still have a great
Right.
quality of life. So it's
Right.
really focusing on that and how to live along with this and manage it that can
Right.
bring you the most success versus just
Right.
being so focused on curing it.
That's such a good point. There's not a cure for migraine that we know of yet. Maybe there will be next week or in 10 years, but right now, we can get you back to quality of life, which again is really what's important. Uh, there's not a cure, but again, we can. What if you just don't have symptoms? What if it goes in remission for 10 years? And there's things, what if you go 6 months with no symptoms at all? Again, my focus is quality of life.
Yeah. Let's talk about some of these questions that I got some readers. A lot of them were heavy on diet.
Yeah.
Um, and I'm kind of curious. So a lot of people ask me if diet can changes can prevent certain symptoms, like can diet prevent vertigo? Can diet prevent head pain? Um,
Yes, yes, and yes.
it's kind of all lumped into one, huh?
Yeah, yeah. The diet is plays a major role in successful treatment of migraine.
What seems
Vertigo again being a symptom, and
yeah,
it may not be true vertigo. We call it true vertigo, the actual rotation of your brain spinning in your head or the room spinning around your brain. It's all vertigo. And again, whether it's vertigo or rocking or unsteadiness, I think diet plays maybe along with stress probably plays the most major aspect of treatment.
yeah, and that's what I'm really finding in my responses from my followers too, is it was very high up there as far as triggers.
Yeah.
What's
And what if we can clean up our diet and we can embrace migraine not as something dreadful? What if this is something really beneficial the universe has given me and it reminds me to be a better me?
yeah,
um, you know, Chronic stress will wreak havoc on your body, and you'll live a shorter lifetime with chronic stress. Makes everything worse. A poor diet, an inflammatory diet, it's probably going to shorten my lifetime. So, I'm grateful for my migraine that it reminds me to do what it is that's good for me that I need to do anyway. I
that's
just changed my perspective.
yes. I that's the exactly what I had to do too. And it was very hard to do because you get so used to living life the way that you were and
Mm.
you're comfortable
Yeah,
with it. And now all of a sudden you're in pain,
yeah,
you're dizzy, and you have to
yeah. Of
be really uncomfortable. And it seems so much harder to do these types of things when you're not
course.
well, you know? Uh,
Most worthwhile things are not easy.
yeah.
There's a reason they call it growing pain. Growing and learning is painful, and you embrace the pain because you're growing and you're being a better you.
Yeah, it's so true. And I'm really thankful that this diet, doing these dietary changes really taught me how to read labels. And I feel like now it's becoming more,
Yeah,
we're seeing it more and we're seeing more of a focus on our food now. But um, no one's really taught us what to look for in labels or how to read
right,
them. And
right.
this is one thing that I think was really positive to come out of the migraine diet for me was to actually be reading those and care about what's in my food.
Right, right, right. And again, that's a positive aspect of having and living with migraine is you're going to pay attention to those things that are probably harmful for you anyway.
Yeah. Is there, so I get this question a lot. Is there a diet that you like? And I have two books that separate these.
Yeah, yeah,
I have the elimination diet book. My
yeah,
Disney cookbook focuses on elimination
yeah.
based finding food triggers, and then I have the Mediterranean migraine diet, which is very
Right.
inflammatory. Do you do you prefer to start patients with the elimination diet to look for triggers and do that, and
Yeah.
then to lead them over to anti-inflammatory, or
Yeah,
like
it's a great place to start. Elimination diet. Again, I just asked them to do this for 2 weeks.
okay, that's not long
Not
at
for
all.
not it's not long, and not 2 months, not 6 months. And again, what if you're feeling better in 4 days?
Okay.
I think there's a lot of similarities in these diets as far as an anti-inflammatory diet, a Mediterranean diet, an elimination diet. There's lots of diets. You can find tons of them if you search it on you Google it and you'll find a bunch of them. Again, I'm most familiar with the one that we used, and it came from a variety of diets. that are used to treat migraine. And again, I'll include that. It's simple, but again, you know this already, and your books talk about this already. So I'm preaching to the choir with you. You already figured this out. So I think you offer some great options and some helpful pathways in treating migraine by changing your diet.
Well, I'm just really interested in how quickly a lot of your patients and the people in this study saw benefits, because for me, it
Yeah.
did take a little bit longer. And so I
Yeah.
just wonder if that depends sometimes on severity, or like, do you see it depend more on people's severity, or do you see
Actually,
it depend on how strict they are or how much they're doing with the lifestyle?
it's strict. It's strict. And again, I don't if a patient's drinking a pot of coffee a day, I say let's taper gently off the coffee first. Get down to zero. Not one decaf or two decafs for zero. And then you start a 2 week strict migraine diet. Because if you start everything on day one, we showed in our study, those patients may be miserable
Yeah.
after a week because they're having rebound headaches and rebound dizziness because of withdrawal from caffeine. So let's get off the caffeine first,
Yeah.
then start a 2 week strict migraine diet. And again, more often than not, those patients were dramatically better. But it's not just the diet. Again, it's a diet and a lifestyle. Diet, I find, is not helpful if you're under high stress.
Mm, interesting. That's a really good point. I think people need to hear that.
Yeah. Or if you're not sleeping well. If someone tells me they don't wake up rested, I send them to a sleep specialist. I make a lot of referrals to our sleep clinic, and help them learn how to get restful sleep.
Mhm.
They
That's
may have sleep apnea, they may just need a CPAP, there are surgical options, but restful sleep is important anyway, not just for migraine.
mm. Actually, that was a big reason for me. I think that I was having an uptick in attacks too, is my low ferritin was actually waking me up in the middle of the night, or I'd have like night sweats with it too.
Right,
Um,
right.
it's sort of hard to know, is this hormones? So I went to my OB,
Yeah, or is it all of that? And
unrelated.
you know, I'm a
Yeah.
new parent. I've got 3 kids, and I can't. Maybe it's just not possible to get restful sleep.
Wow.
So let's focus on those other triggers.
Mhm.
And again, maybe in non-pharmaceutical ways, we can learn to let go of the stress and to have more peace of mind. But again, there's rescue medicines that can change a person's life in situations where they may just not be able to get restful sleep or have low stress.
Yeah. Let me see. Are there any main trigger foods you see? I think we discussed this with like the
Yeah,
caffeine.
caffeine again, probably number one.
Yeah, same here. And then do you ever see a link between celiac disease and gluten-free and vestibular
I
migraine?
do, I do, and I'm always amazed. And again, I'm continuously learning from my patients. I have patients who have celiac disease and their own an anti-inflammatory diet, and now I'm going to turn around and ask them to give away other foods. So again, they have a double win. They have an additional difficulty in doing these things. I encourage those patients. Let's find out what works for you. And again, I promise you're not going to have to do the strict mind diet forever. There
Yeah.
may be 3 or 4 that are on the list that are your only triggers. So I think you can live successfully with both IBS and celiac disease, other GI inflammatory conditions, and vestibular migraine, um, and POTS, and these other things that have a high comorbidity. I see a lot of patients who have POTS and they have vestibular migraine. So again, I think it's fascinating, and I'm excited that we're learning about this. And I can't give you the answer of why those comorbidities exist, but I see it every day, and I believe my patients, when they tell me these things are both going on.
Yeah, yeah, and that's great too. I do see gluten be more of a trigger for people who have that
Yeah,
sensitivity.
I agree. I agree completely.
Yeah. So someone asked, where can I find this information if my provider doesn't believe in dietary changes, but we
Oh,
believe that?
I don't know,
And-
Alicia. Maybe it's time to find a different provider that's not so heavily. Let me give you this pill or these 6 prescriptions, and I'll see you in 6 months. I don't think that's the best way to treat vestibular migraine. We have to have a more holistic, integrative approach, I think, to have a successful outcome. I think the answer is not just, um, again, if my provider or I hear this that patients won't do it, they won't change their diet. I strongly disagree.
Yeah.
So let's start there. There's no risk in doing that.
You know what I've seen is like whenever I have given people the resources or like here's a meal plan for you to make all of these migraine
Yeah,
meals,
yeah.
it helps them so much to understand like, oh, this isn't as hard as I thought it was going to be. There's
Mm-mm,
actually a lot I
mm-mm.
can eat on this diet, and it is only temporary too. So
Correct.
overall, I think if you can support patients in that way,
Yeah.
it makes it a lot easier for them to act.
And maybe I need to get a dietitian involved,
Yeah.
and I'll do that. I think there's a great role for that, and help these patients find the foods that won't make them sick and will allow them to feel better.
And making sure they're getting in that proper amount of
That's
protein,
that that's
fat.
correct.
Yeah,
Yeah,
I myself, as even as a even as a recipe developer, I also have my own dietitian that I work with, and she's helped me a lot
great,
with like the iron component and everything.
great. I'm again. Let's integrate multidisciplinaries.
Are there any things, we kind of talked about this too with the extreme nausea and doing the Zofran as well. Are there any
Mhm.
natural things that you see helpful with the nausea part of things?
That's again something that I learned from my patients and essential oils patients. Some of my patients, I don't have any firsthand data on that. I've not tried that.
Yeah.
Zofran works great for me, and it's easy.
Mhm.
But essential oils, peppermint again, and again, I think Alicia, you could probably speak more to that than I can as far as dietary um, uh, ingredients that will help reduce nausea.
Yeah, I have a lot of people who have success with ginger, and so I've been
Yeah.
making these lately with like a homemade ginger ale and a ginger
Yep.
smoothie.
Yep.
Um,
I have ginger ale for my patients in the clinic. I give
yeah.
them a mini can of ginger ale. I was able to get off of caffeine. Like, what are you going to do in the morning? That's my routine, and I've been doing it a long time. And I was able to find I drug out a juicer that I had in the cabinet, and I've never been opened. And I
Okay.
started after I finally said, you know what, I can't do this anymore. I had to cancel clinic 2 or 3 times in a month because I couldn't get out of bed. That's just not an option. Even doing a few sips of decaf. So I got my juicer out, and I would put pineapple, and I would put apple, and I would put carrots, and I put kale, and I would add ginger and turmeric, and they taste good and they're migraine preventatives. So ginger and turmeric are well established as as nausea and migraine preventatives.
Mhm. And I've noticed a difference too whenever I've incorporated ginger, just like
Yeah.
natural ginger.
Yeah.
Not
It helped giving up my caffeine easier because they tasted good, and I found that just as satisfying as my coffee, which was making me sick.
Yeah, it's
Um,
interesting you had the same issues as me. Like, I feel like if I could just tell people, like, giving up caffeine, you don't have to stop it right away, but
yeah,
you
yeah,
really do have more energy in the long run. Like, my husband
yeah,
was relying on it when we had our kids, and I'm like, well, I'm just up, like,
yeah.
whereas he couldn't function unless he had it, and
Right,
you get used to
right.
living with
Be
it.
be kind, be kind to yourself, and
Yeah.
and take it off gently. Don't be harsh. Some people just want to cut it all out, and they go through that week of misery, and
No.
and that's okay too if you want to do it that way. But I recommend gently coming off of caffeine to the point you're at zero.
Do you have like a weaning schedule that you recommend to people?
Usually, it depends on how much they're on.
Mhm.
Again, some are drinking a whole pot,
Yeah.
and some are drinking. They say, "Well, I'm only drinking two." Well, I would consider that's a lot.
Yeah.
Well, maybe they think that's not a lot. And again, for me, even a half of a decaf was a major trigger.
Mhm.
So again, you say, caffeine will never be good for you. Caffeine will never be your friend. And I've learned, I've moderated on that position that I told patients 15, 5 years ago. I say, if you're getting good sleep and under low stress, you can do your cappuccino and if it brings you joy.
Yeah.
But let's get it under control first before we start reintroducing any caffeine at all.
Yeah. I'll have to send you this. Now I'm thinking, oh my gosh, I'll have to see how you do with this. But I recently tried a caffeine alternative called Kamana. It's a
Really?
caffeine-free coffee substitute, and it's made out of
Wow.
mesquite. So it's
I'd
got
love to know more about that. And again, I
yeah,
learn from my
like
patients, I learn from you, and that's why it's so exciting.
we find all these weird things when we don't have
Yeah.
any
Yeah.
of
We're curious. Curiosity is really important in
yeah.
having a successful outcome.
But I love how low acid it is, and it actually makes a great iced coffee alternative. But
Wow.
it's made out of mesquite wood, so
Hmm.
it's kind of interesting. You think, oh, how is that? But then you have that.
I wonder, but I'm always willing and I'm curious. So
Yeah,
I'd love to please send it to me
I'll
and
have to
I'd love to try it and share it with my patients.
yeah, and I'll add a little link to it in this program too.
Okay.
Just
Awesome.
to round up our, everything we talked about, I know we hit on the neuromodulation devices, and I really want to
Yeah.
cover that before we end this. You and I have both had experience with this, and this is a great alternative to
Yes.
medications that can be used both acutely and preventatively without risk of overuse. Um,
Right.
so let's talk about a few of those and your experience with them.
Sure. Personally, and again, I joined the American Headache Society and went to their meeting in Scottsdale in November, and I went to the trade show and just to learn about the neuromodulators. And the
Yeah.
first one I came upon was Nerivio.
Yeah.
And it'd been a long day. I'd been in classes all day and lectures, and I had a headache.
Yeah.
And the person, the rep there said, "Oh, great, put this on. In 15 minutes, your headache will be gone." And I
Mhm.
did. And it looks like it's kind of like an old iPod when you're working out, and it has a little strap, and you can put it on a little sticky thing. And in 15 minutes, my headache was gone. And I continued to look through the trade show, and I went to Cephaly, and I sat back and they put that on also. I think my headache was always already gone from the other device. So, but I was very open to that. And again, I met with those guys last week at Cephaly, and I'll be having demos that I can use for my patients, and I'll try it myself as well. I think it's probably their science is different. Cephaly's a TENS unit, and whereas Nerivio is a remote. It doesn't matter if you don't have to put it where the headache is. You can put it on your arm, and it affects ascending and descending nerve pathways. It affects nerve pathways a little bit differently.
Yeah.
But I think they're both great options, and I don't think there's any risk to doing them. I've yet to learn about gamma core, and you've mentioned some of the other ones. But I think they're a fantastic option, another layer of treatment. And again, we've got lots of options as the student migraine sufferers in ways we can treat this successfully.
Yeah, it's so Nerivio that we talked about and Cephaly both work on the trigeminal nerve
Right.
in this area. And then gamma core and devices that are vagus nerve stimulators, gamma core, Truvaga, and Pulsetto work on your vagus nerve, which is
Hmm.
responsible for that brain connection. So I
Okay.
personally found gamma core to be very helpful when I had vestibular migraine
Interesting.
and nausea and vomiting.
Yeah. Yeah.
And I used it a lot during my pregnancy, actually.
Wow.
My OB had approved it during pregnancy, but some of these do require prescriptions. So
Hmm. Hmm.
Cephaly and Truvaga you can do without prescriptions too,
Sure.
as health devices. Truvaga is a health device.
Sure. Sure.
So it just kind of is a little bit of trial and error, isn't
It's
it?
a trial and error like everything else. It's I'm eager to explore Gamma Core, and I've got a meeting next month with those guys, and I'm eager to find new resources for myself and for my patients. One other thing we haven't talked about that I think is another layer of treatment that's important is the supplements.
Yes.
There's good science and peer-reviewed journal articles And the information I put in my packet to my patients, I recommend vitamin B2. I recommend magnesium in various forms, whatever one's tolerated the best. I recommend CoQ10, and
Okay.
I put the dosages with that. And again, I'll supply that information to you that you can post.
Okay.
Some of my patients tell me ginkgo biloba is one that's helpful, and so I've added that. I take a handful of supplements and I travel with them, and I take them every morning. And I think the data shows it takes a month or two for those to start working. They're not going to work tomorrow. So
Mhm.
it's a long-term plan that we have. And again, it's another layer of treatment that if this layer fails, I've got another layer that's going to catch me so I don't have symptoms.
Do you see any one of those supplements work better than others? Like if, or they
I've
all,
not personally. Again, I use a combination, and I don't ever recommend them in monotherapy. Here's a handful, and again, the side effects are going to be minimal, if any. And again, it's do no harm, and I think they probably help a lot of other things at the same time.
okay, that's really interesting. Is there anything else that we missed that you think it would be helpful for patients to
Sure. There is a high comorbidity in various types of acute dizziness, frightening dizziness, in which those patients do develop something that used to be chronic, called chronic subjective dizziness. Now it's called triple PD or 3PD. And again, that's something that has to be addressed. Personally, I found that if we get rid of the frightening cause of the dizziness, we get that under control, we get the vestibular migraine under control, or we're probably going to have a real good outcome with the triple PD. But I had a patient last week who was teared up. She was just terrified that this was going to continue the rest of her life, or it was going to get worse. What if I have an event tomorrow? And she was terrified, clearly had comorbidities in triple PD. And again, for those patients, there may be the need for SNRIs or SSRIs or psychotherapy, talk therapy. I send patients to those again, or strategies like meditation. It's a very real diagnosis, and there's a high comorbidity, and it should be recognized and should be addressed.
Yeah. How often do you see patients with vestibular migraine also have triple PD?
I think the data shows, you know, 40, 50%.
Mm.
But it's kind of all jumbled up together, it's hard to know. But I found if we get their vestibular migraine under control, we improve their quality of life. The fear that this is going to never go away, it kind of evaporates. So we're kind of treating both conditions at the same time. There are exceptions that may need therapy, psychotherapy to work through that frightening event. And their brain is living in this state of fear that this is going to occur again, and it's just a recycling kind of thing.
Yeah.
So those may need additional treatment with a therapist.
That's really interesting you mention this. So back when I was diagnosed with vestibular migraine, triple PD wasn't really a thing. This
Hmm.
was like over 10 years
Hmm.
ago,
Right,
around 10 years ago. And I think it was just starting to kind of be researched. And, so I was diagnosed with vestibular migraine, chronic vestibular migraine,
right,
I think is difficult because the ICHD3 classifies vestibular migraine as more of an episodic event where we
right,
know like it can be constant and have these symptoms.
right, right,
You have things like interictal symptoms that happen in between the attacks, or you could have
right.
triple P
Sure.
that is constant. So we didn't really know that I had triple PD at the time, but now looking back, we
Yeah,
think that it had a
like it makes sense now.
and treating the vestibular migraine did eventually help. But I'm curious how you tell patients, and I can add my own perspective here, but how you
Hmm.
tell patients to distinguish between the vestibular migraine and the triple PD.
It's again those patients that I see that clearly have triple PD are terrified. They're just terrified, and again they tear up. They're emotional. It's like there's more than one thing going on here, and we may need to address this. Let's say we get let's say we get the vestibular migraine under control, but they still don't have the peace of mind. They're not having dizziness, they're not having headaches, but they're not having quality of life. So there may be then, and that's why the quality of life metric surveys are so important.
Yeah,
At those points that maybe we need to talk about therapy. There's also the role of vestibular rehab therapy, prevalence therapy. That's another important tool in the toolbox. I don't send patients to vestibular rehab therapy who are in full-fledged acute vestibular migraine. It will make them miserable because the
me.
exercises are involved in quick movement. They're moving their eyes, and that's a common trigger for vestibular therapy, and they're miserable, and they don't continue it. So let's get the vestibular migraine in control. And if they still maybe have triple B PD, or maybe they still have poor balance, then we send them vestibular rehab therapy, and they'll have an excellent outcome.
That's really interesting. Yeah, vestibular therapy ended up working for me on more positional issues that I had after I got my dizziness under control. But I
Right,
initially
right,
vestibular therapy
correct.
pushing me when I was highly symptomatic, and it just made everything so much worse. So it is a very fine.
Right. Who wants to do that? That makes me feel
Ah,
awful.
and the eye
And you're
exercises
telling me for 15 minutes a day to do this.
it's
Yeah.
terrible.
Quick
Yeah.
eye movement triggers vestibular migraine, so let's take one thing at a time and let's not get ahead of ourselves.
Yeah, that's a great point. Well, thank you so much for your time today. I really appreciate it and your
Mm,
all your research on all these natural treatments that we can do to help ourselves, diet and lifestyle. It's very important because
mm,
a lot of times
yeah.
as patients, I feel like we get a little gaslit when we ask our doctors about some of these things. It's nice to have someone who's coming in with the research and
Right,
in their clinic to confirm that this is a worthwhile
right.
while of your time. Yeah. Is there
There's good science behind this.
and that's what we need, but unfortunately there's not a lot of
Mm,
money behind it. So
right, 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 right.
we need people like you who are researching the stuff to put the
Sure,
time into it.
sure.
Yeah. Is there anywhere
Eh,
that patients can go to see you or get in touch with you?
Sure, I'm at Vanderbilt, and I'm in the Department of Otolaryngology and the Division of Otology Neurotology, and I'm happy to see patients. And again, I can include that information. You can search my name at Vanderbilt, and you'll find the information on Google. But I'll include that in the comments for you to post.
And then if people are out of state, can they also drive to see you or how would they?
Yeah, I see patients from all over the Southeast region. I've seen patients internationally. I think it's fulfilling. Not everybody wants to treat dizziness, to be honest with you. I work in a surgical specialty, and you're probably never going to get a surgery out of vestibular migraine. I'm a non-surgical otology, neurotology clinical associate professor, and I'm passionate about non-surgical options. There's a role for surgery, but probably not with vestibular migraine. So finding someone who's passionate about treating this and not necessarily looking for surgery, it may be important.
That's really interesting. Again, thank you so much for your time today. I'll have to have you back once
I'd
you
love
finish
to.
this other study that you're doing.
Yeah, yeah. I'd love to see what the results of the head-to-head amitriptyline
Uh,
diet lifestyle modifications is going to look like.
I'm really curious about that too. Thank you so much for your time, Dr.
You're
Watford.
very welcome, and thank you for being such a huge resource for my patients. Every vestibular migraine patient I've ever had knows all about the Dizzy Cook and knows all about you, and that's how I met you was through my patients.
I really appreciate that. You know, I love being sort of the middleman to connect people with their
Yeah,
physician
yeah,
that helps them get to
yeah,
the next step.
yeah. You've changed people's lives.
Yeah, thank you. You as well.
Thank you.
We'll wrap this up by saying we'll put all the information here below and all the resources
Mhm,
that Dr. Watford's going to send me. And
mhm.
then you can always visit me on thedizzycook.com. And
Yeah,
please add any questions in the comments. We appreciate you.
yeah. Thank you, and enjoy your day. It's been my pleasure.